tears which have been already shown. I'm going to show you a few scenarios and what we can do about them. So this is a lateral meniscal tear. You can see it actually doesn't fall into any pattern. There is a lot of slough. You know it is a chronic tear. And then as I probe, you see some mucus fluid coming out, which was a parameniscal cyst. There is a small flap there. This fellow is only 22 years old, maybe a discoid lateral meniscus which has gone bad. So you try to trim things and try to understand what type of tear it is. Now you see a cleavage. I like to use the small shaver. This is the small 2.9 shaver. I use it to debride and create biology there. Of course, you bring in your diamond rasp and create biology. Now you kind of have an understanding of the tear pattern, but when you went in, you didn't know what was happening. So debriding and reassessing again is very important. Now I take the bigger shaver and then just do the suction. Both the leaf, the anterior and posterior part of the meniscus started closing in. So which means it is unstable. Now that is my first reduction stitch starting somewhere in the body to keep things in place. This is an all inside device. You've seen few of this. But what is important is you keep a probe there and then make sure you don't over tighten. You gradually tighten that and try and maintain biology there and don't squeeze it too much. Don't try to compress it too much. Now I bring in my knee scorpion and I take a transverse mattress stitch. It's a horizontal mattress stitch. I take two of this and tie that down. Now I do a different trajectory, a far medial portal to bring in my all inside device. Inside out device. So you have to be versatile. You have to think of all the options. You have to have all your armamentarium in place so that you can do a good job. And then I go on and do a outside in for the anterior on. And this is a very simple thing. You can do it with your IV cannulas or just a 21 gauge needle. So one loop and a stitch, and then I reassess. I think there needs to be another horizontal mattress there so that the horizontal cleavage there sits well. Like Dr. Mohan said, every 3 millimeters to 5 millimeters, you need to have a compression for the healing to happen. That will give you excellent mechanical stability. So I go ahead and then do that again, this time with a different color. That is again another horizontal mattress, and then retrieve it and tie them down. So before you, and now as I'm doing it, you can see the popliteal fossa and the hiatus being recreated in normal tension. You know that things are falling back in the periphery in the right level because you need the peripheral end of the meniscus to sit well so that the hoop stresses are maintained and OA doesn't happen. And then I understand that there needs to be one more stitch anteriorly. So I bring in one more anterior on stitch. This is again an outside in maneuver. And tie it down. Now I bring the, after my repair, I bring the shaver now. And now you can see that the anterior and posterior parts of the meniscus don't close in when I put suction, which means the repair is stable. So from how it started, I've tried to give him a relatively nice looking meniscus only in the periphery, and we have avoided cartilage damage during the procedure. Of course, again, to increase biology, go over the top of ACL in the notch and do the microfracture so that good material coming to heal. So this is another case. Again, lateral meniscus. This is a young fellow. You can see the root looks okay, but there is a bump. Again, I bring in my mini shaver to go and debride the undersurface, because without creating biology, you can never repair because it is going to fail. So biology first, mechanical stability next. So bring in your knee scorpion, a mattress there. These are 2-0 or 0 fiber wires, so they really don't hurt the knee. And this is a 32-year-old man. So again, he's neglected it for a long time. And you can see the ACL is also absent, so he's going to undergo an ACL. So I'm a little bold in repairing this because it's going to heal. Now, you see a flap there. and one part of the flap has to go. That part has to go because that is completely avascular zone. That is the white zone. So your repairs chronic repairs might always be a combination of meniscectomies and repair. So I bring in my shaver and then the diamond rasp. Now I try and reassess the reduction. You see, I think that reduction is going to be nice to give us a circumferential meniscus there. So don't start deploying anchors or your scorpions without understanding the reduction strategy. So plan your reduction strategy, protect that knot with another all inside device here, taking care not to over tighten it. The popliteus aortus tension is maintained. You always have to look for that. And because now I know I'm going to do an ACL for him, I know these things will heal because there is good material going to come from the ACL tunnels. Always they allow it to heal well. So that's how it finished. Now, last scenario. One more minute. I'll finish. So this is a 49-year-old man. I have done some pie crusting. You can see the medial side opening up. This is the medial meniscus. And you see a flap there. Oh, I'll still finish. You see there's a flap there. Now, reduction strategy. I want to see how it reduces. This might not be reducible. So what will be my strategy? You can be godly. Don't try to play God. This cannot be repaired. So I'm going to bring in a punch and do a very simple meniscectomy. Yes. And that solves everything. So thank you very much. And I invite you for the LSD course in January